Thiazolidinediones or Deans or something like that.
Thiazolidinediones. Yes, that is correct.
I just say TZDs, y'all.
There you go.
TZDs.
That's
They try to get us out here with that long.
So
anyway. Hey guys, welcome back. I am Dr. Jemecia Capri, the Nurse Practitioner Extraordinaire, and I'm so excited because I have Dr. Bradley here with me today, and we are going to talk about, hold on, let me see if I can get this right, y'all. We are going to talk about type 2 diabetes and what it is, the medications that you would prescribe for that, and if you're interested in type 2 diabetes, stay tuned. Hey guys, we're back, and today let me get this right, y'all. Sorry about that. Today we are here with Dr. Bradley, and she is going to give us her expertise on type 2 diabetes. And I felt like this was really important to you guys as new nurse practitioners, as nurse practitioner students, trying to kind of like muddle your way through all of these new diabetic medications. Sorry about that, but I'll turn my phone off here shortly. But new diabetic medications and some of the older stuff and the mainstays and what we should be prescribing. So thank you for being here, Dr. Bradley.
Thank you for having me.
So Dr. Bradley is a pharmacist, and I would like for her to give a little bit of background on herself and why she decided to become a pharmacist.
Good morning. I decided to become a pharmacist because I knew I wanted to help people in the medical field. However, I did not want to touch anyone. And just so you know, pharmacy runs in my family, so that's another reason why.
Awesome. Okay, so let's just jump right in. Type 2 diabetes. Tell us about what type 2 diabetes is.
Type 2 diabetes is a chronic condition where that affects the body's ability to process blood sugar. It is typically caused when the pancreas cannot produce enough insulin or when the body becomes insulin resistant. The body has a resistance to insulin.
Okay.
Typically, the cause is unknown. It could be genetic, or it could be when a person doesn't exercise enough, physical inability, when they have weight gain.
Obesity.
Yep. So those are typically some of the contributing factors to diabetes.
Okay, good. So I know that with you being a pharmacist, you have to keep all these medications in your head. Is there any tricks that you use for keeping track of all these medicines?
So typically I try to track medications by disease states. I try to remember, and within those disease states or the classes of medications, and I try to remember what's different about one or two medications in that particular class. Of course, you have your guidelines. Those act as a roadmap, and that's exactly what it is, a roadmap. If you ever get stuck or you need to know which way you want to go with the patient, then you would, refer to the guidelines.
Okay, so say I am a new nurse practitioner, I'm in the clinic, I just get a patient in who I have just diagnosed with type 2 diabetes. What are some of the first line medications that I can use?
So Metformin is going to be your first line of drug therapy. Second line will be your sulfonylureas, the Glyburide, then the Thiazolidinediones, the DPP4 inhibitors, and the SGLT2 inhibitors are typically further down the line due to cost.
Cost, okay. That was a mouthful. So let's just throttle back a little bit.
Okay.
So I know with the sulfonylureas, we don't use those as much as we used to. Now I know, I want to say, and correct me if I'm wrong.
Okay.
Sulfonylureas were out before Metformin, yes?
That is correct.
Okay.
Yes.
So they're just old school.
Old school. And
right.
One tidbit of information about the sulfonylureas, you want to make sure that you give them 30 minutes prior to a meal. You want to start at the lowest dose possible because they do typically cause hypoglycemia. Versus Metformin, you can jump right in, and the cause of hypoglycemia is relatively low with that particular medication. However, with Metformin, you do need to watch out for the GI side effects, the nausea, the stomach cramping, the diarrhea. And if the patient has persistent GI discomfort, you can try the extended release formulation.
Yes, okay, that was a mouthful too. Let's just throttle back a little bit. So with the sulfonylureas, and the reason why I don't prescribe them as much is pretty much what you said. The fact that they cause hypoglycemia a lot. And so I don't reach for those as much, but I have used the sulfonylureas a little bit along with metformin.
That is correct.
In order to get some better control and to bring that hemoglobin A1C down.
That's correct.
I've done
and
that.
Not only is it good to be used in conjunction or combination with the metformin, but in the elderly, you want to watch out for Glyburide because it has a long half-life, and we don't want to, that in the elderly.
Okay, that is good stuff. That is good stuff. Okay. So now that we talked about the sulfonylureas, we talked about the Glyburide, now let's talk about, you did mention that you will go down the line and we would do the Thiazolidinediones or Deans or something like that.
Thiazolidinediones, yes, that is correct.
I just say TZDs, y'all.
There you go.
TZDs.
That's right.
They try to get us out here with that long.
So
anyway,
the one again, those you have to give 30 minutes prior to a meal. You want to use the lowest dose, hypoglycemia. However, that particular category of medications carries a black box warning, and you want to avoid use in patients with congestive heart failure. So just keep that in mind.
I didn't know that, y'all.
Yes.
Look at Dr. Bradley dropping all these nuggets. Okay, so the TZDs, like that's the rosiglitazone.
And pioglitazone.
And pioglitazone.
Yes.
Okay, y'all. And so I don't reach for those either, guys. I just don't, but I know they're out there. You may use them. They're there to be used. And there's gonna be a patient that you might find that works good. So now you did mention DPP4s and the GLP-1s. I think we need to talk about those kind of together.
Okay, that is good. Okay. So the DPP4s and the SGLT2 inhibitors are some of the newer kids on the block. Those are your saxagliptins, linagliptins, the liraglutide, the semaglutide. Ooh. These agents are typically, actually both of them really, can be used for patients with cardiovascular disorders. So,
is that like the Farxiga?
Farxiga.
Okay,
That's right.
Yeah, they advertise that a lot, y'all.
Yes, that is correct. The SGLT2 inhibitors are your injections. So the difference in those are they're either weekly or daily. The two newer ones are the semaglutide and the dapiglutide, and those are dosed weekly. And typically in these medications, it's for patients who are already on metformin, possibly another agent, but who are also using diet and exercise to control their diabetes. And this is just one extra addition that can help get them down, get their A1C down a little further. So it's not for the patient who has a long way to go in decreasing the hemoglobin A1C in their medication therapy.
That does make sense.
Yes.
So let me ask you this about that. I am wondering about those injectables. Are we seeing that people are okay with wanting to use that? If that's the case, my thing is, why are we not using insulin?
Insulin, okay, so let's back up. Insulin is going to give you your highest efficacy. End all be all. You need to go from an 8 to a 7 instantly, it's going to be insulin. However, you're going to have to watch for the hypoglycemia. With insulin, you want to titrate to clinical dose, and in patients who are renally compromised, you want to make sure that the dose of insulin is not too high. So that's something else you need to watch out with insulin. But in the newer agents, the SGL2s and the DPP4 inhibitors, they're not going to be your first line of medication therapy. It's going to be addition.
Okay, so that was a mouthful, and I think we're going to make a part 2. So if you guys would stay tuned for part 2, we're going to talk a little bit more about the DPP4 inhibitors and the SGLT2s and incretins or whatnot therapy. Okay, so hey, stay tuned and tune in to part 2.